Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. On this episode, I will cover a non-interpretive skills subject of periprocedural care. On the surface, this may seem straightforward, but as with many things in the non-interpretive skills portion of the examination, there are details that you may not be aware of that are highly testable, and I will try to focus on these highly testable details on this episode, again in question and answer format. The questions and answers from this episode specifically refer to information that is presented on the 2021 version of the American Board of Radiology Non-Interpretive Skills Study Guide that is available online at the ABR website. I will make the study guide for this episode freely available for download on my own website, theradiologyreview.com, and this episode is a reminder for all of those who have the core exam in your future that the non-interpretive skills portion of the examination should not be overlooked or necessarily underestimated. Even though you are provided with a fairly comprehensive study guide from the ABR, there are details in these questions that can be tricky. Let's go ahead and get started. After one plug to follow at RadRev Podcast on Twitter or Instagram, where I am currently posting on a near daily basis tips for the physics portion of the ABR core exam, and I occasionally have other board relevant material that I present there as well. Let's get on with this episode. First question. How many patient identifiers need to be confirmed during a timeout prior to a procedure? According to the Non-Interpretive Skills Study Guide, at least 2 patient identifiers should be confirmed prior to a procedure. Next question. What are specific patient identifiers discussed in the Non-Interpretive Skills Study Guide? The specific patient identifiers that are discussed in the Non-Interpretive Skills Study Guide include patient name, medical record number, telephone number, date of birth, government-issued photo ID, or the last 4 digits of a patient's social security number. Again, you need to confirm at least 2 of these prior to a procedure. So that is 2 of the following: patient name, medical record number, telephone number, date of birth, government-issued photo ID, last 4 digits of a social security number. Next question. True or false? A patient's current room number can be used as a patient identifier prior to a procedure. The answer here is false. Something like a patient's room number in the hospital is considered a, quote, transient factor, end quote. A transient factor, according to the Non-Interpretive Skills Study Guide, is something that is not permanent but could change, such as a patient's room number. So something like a room number that is a transient factor cannot be used to identify a patient prior to a procedure. Next. True or false? If you are unable to verify patient identifiers with the patient because the patient is unable to verify their own identity, such as an unconscious patient, a relative, guardian, domestic partner, or healthcare provider who has previously identified the patient can be used as a source to identify the patient. The answer here is true. The Non-Interpretive Skills Study Guide also states that if there is a discrepancy between patient identifiers of any variety, the procedure cannot be completed until additional information is obtained to confirm the patient identity prior to proceeding with a procedure. And again, this question states that it is true that if the patient is unable to verify their own identity due to something like altered mental status or loss of consciousness, you are allowed to use a relative, guardian, domestic partner, or healthcare provider who has previously identified the patient to confirm the patient is who you think they are prior to performing a procedure. Next question. For patient assessment prior to sedation, what are some key variables to assess in order to ensure that sedation is safe for a patient? To be approved for sedation, an accredited practitioner must assess for the following: recent oral intake, adequate pulmonary and cardiac status, vital signs to include pulse oximetry and capnography if available, EKG if available, baseline level of consciousness, and any recent illness. Next, can you list the 4 levels of sedation according to the Joint Commission and the American Society of Anesthesiologists? The 4 levels of sedation, according to the Joint Commission and American Society of Anesthesiologists, are 1. Minimal sedation or anxiolysis, 2. Moderate sedation/analgesia, 3. Deep sedation/analgesia, and 4. General anesthesia. So again, minimal sedation, moderate sedation, deep sedation, and general anesthesia. Those are the 4 levels of sedation. And that leads us into the next question. Can you define key features for each of these 4 levels of sedation? First, let's talk about minimal sedation. Minimal sedation is a medication-induced state that causes reduction in anxiety. Minimal sedation is not too deep for a patient to respond to verbal commands. There may be impairment of cognitive function and coordination. The patient is breathing on their own, and a patient has stable cardiovascular function. Let's move on to moderate sedation. With moderate sedation, consciousness is minimally depressed due to pharmacologic agents. The patient is able to maintain their own airway. The patient has protective reflexes, and the patient can be aroused by physical or verbal stimulation. Next, deep sedation. Deep sedation involves a deeper sedation state in which consciousness is depressed due to administered pharmacologic agents. The patient in a deep sedation state cannot be easily aroused, but does respond purposefully after repeated or painful stimulation. The patient may not be able to maintain their own airway or maintain adequate ventilation without some sort of intervention. With deep sedation, cardiovascular function is usually okay without intervention. Finally, general anesthesia, and this is a controlled state of unconsciousness. With general anesthesia, there are no protective reflexes, a patient cannot maintain their own airway, and the patient is not able to respond appropriately to pain. Let's move on. True or false? Minimal sedation patients do not require monitoring. The answer here is false. Regardless of the intended level of sedation, all sedated patients require appropriate monitoring. Patients may rapidly move between levels of sedation, and a deeper level of sedation may be obtained than was initially planned or desired. Therefore, you always need to monitor patients who have been sedated to any level. All sedated patients require monitoring even if minimal sedation is planned. Next question. How many classifications are there in the American Society of Anesthesiologists Physical Status Classification? And can you name some details about each of these American Society of Anesthesiologists Physical Status Classifications? First of all, there are 6 levels of classification within the ASA Physical Status Classification, and these are as follows. Class 1, Normal, Healthy Patient. Class 2, Patient with Mild Systemic Disease. Class 3, Patient with Severe Systemic Disease. Class 4, Patient with severe systemic disease that is a constant threat to life. Class 5, patient is moribund and not expected to live without the operation or procedure at hand. And finally, Class 6, patient with brain death undergoing organ removal for donation. I do think it's important to know details about each of these. You can imagine it is relatively easy to write a multiple choice question on this topic. You can review this on the source from the ABR Non-Interpretive Skills Study Guide, or you can also review it on the study guide I will make available on my website for free download. Next question. True or false? Class 5 ASA Physical Status Classification patients may be sedated by a non-anesthesiologist. The answer here is false. As a reminder, a Class 5 patient is a patient who is not expected to live without the operation or procedure at hand and is a moribund patient, moribund. And to make sure it is completely clear, a moribund person is a person who is at the point of death. The answer to the question is that Class 5 ASA Physical Status Classification patients may not be sedated by a non-anesthesiologist. These patients require specific skill that non-anesthesiologists simply do not possess, and Class 5 patients should only be sedated by anesthesiologists. Next, what ASA Physical Status Classification classes require at least a consultation with an anesthesiologist or anesthetist prior to performing an operation? At what levels do you need to first consult with the anesthesiology specialists? The answer here is Class 3 and Class 4 patients. These are patients that require a radiologist overseeing sedation to first at least consult with an anesthesiologist or anesthetist. As a reminder, Class 3 is a patient with severe systemic disease, and Class 4 is a patient with severe systemic disease that is a constant threat to life. Next question. True or false? A separate qualified healthcare professional whose primary focus is monitoring, administering medications, and care of the patient is required when sedation is performed under the supervision of a radiologist. The answer here is true. Continuous monitoring includes things like level of consciousness, respiratory rate, pulse oximetry value, blood pressure, heart rate, and cardiac rhythm, and that is a lot to keep track of while the radiologist is also performing a procedure. Therefore, you do need a separate qualified healthcare professional who has a primary focus on monitoring, administering medications, and care of the patient while under sedation. Next, patient monitoring must continue at least how many hours following administration of a reversal agent? The answer is that a patient must be monitored for at least 2 hours after administration of a reversal agent, or else the patient may risk relapsing into a deeper level of sedation. Remember that a reversal agent for anesthetics may have a shorter half-life than the sedating agent, and therefore it may wear off, and the sedating agent is still on board, and the patient falls into a deeper level of sedation. It is therefore important to monitor the patient at least 2 hours after administration of a reversal agent, so if the patient does enter a deeper level of sedation, you will be alerted and can respond appropriately. Next, What is the universal protocol that must be followed prior to each procedure? The universal protocol refers to 3 steps prior to a procedure. First, pre-procedure verification. Second, marking of the procedure site. And third, pre-procedure timeout. Next, what are steps to perform during pre-procedure verification? The Non-Interpretive Skills Study Guide describes the pre-procedure verification as an ongoing process to ensure that all information and equipment necessary for the procedure are available prior to procedure start, correctly labeled and matched to the patient, and reviewed and consistent with the procedure to be performed. Next, what are steps to perform during the marking of a procedure site? This is a great example of a question that seems very simple on the surface, marking a procedure site. In your mind, I'm sure you all think simply marking an X on the skin over the surgical site. However, the procedure site should be marked when there is more than one possible location at which the procedure could be performed, and performing the procedure at a different site may harm the patient. So there are certain scenarios when the site may or may not be marked. Additionally, a licensed independent practitioner who will be present during the procedure must mark the site. In certain cases, this task of marking the site may be delegated to residents, PAs, APRNs, and so forth. The mark must be visible and made in a manner that won't easily wash away when prepping the skin. Additionally, some areas are difficult to mark, such as mucosal surfaces and so forth. In such cases, follow your organization's written alternative processes that determine how to proceed. Note also that marking on premature infants can potentially cause a permanent tattoo, so in such cases, alternative processes should first be established by the institution and subsequently followed. Last and final question for this episode. What are steps to perform during a pre-procedure timeout? Hopefully, the answer to this question is second nature because you are in the habit of performing high-quality timeouts in your clinical practice. However, let's go ahead and review to make certain that we get these questions right on radiology board examinations. First, during a pre-procedure timeout, this should be conducted immediately prior to starting an invasive procedure, such as immediately before making an incision in the skin. It is bad form to do something that starts the invasive portion of the procedure, such as making a skin incision, before a timeout is performed. The timeout should be started by a designated team member and involves all immediate team members, including nurses, techs, the anesthesia team, and so forth. During the timeout, all relevant members should actively communicate and voice agreement or dissent with the following: correct patient, correct site, and correct procedure to perform. Follow your organization's policy regarding how to document the timeout. That is enough for now. I hope these questions and answers will be helpful for many of you. Remember, if you are listening to this episode in a future year, that the ABR may have a more updated version of the Non-Interpretive Skills Study Guide, and I would encourage you to check this information with the newly updated study guide, as this study guide does tend to change, at least in minor ways, from year to year. If you want to review these questions and answers in written form, you can download the free study guide on this topic available on my website, theradiologyreview.com. If you would like more non-interpretive skills topics, please let me know. You can reach me through email at theradiologyreview@gmail.com. You can also send me a message through Instagram or Twitter at RadRevPodcast. Thank you for listening to this episode. Keep up the good work. Study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.